Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. My name is Terry Fletcher. Today, we are at the 156th episode of the Codecast Podcast. And today, as we are in the fourth quarter of October, we've had some breaking news with Medicare. Actually, it came out today, the day that I'm recording, which would have been the 8th, so you're going to hear it on the 13th. But I wanted you to have it because it's going to be important for those offices that actually applied for and received payments issued under the Accelerated and Advanced Care program. So the Accelerated and Advanced Payment program, I should say, that Medicare allowed for during the pandemic. Now, I did discourage it because you are basically taking a loan from future Medicare payments. Well, because the pandemic has been going on for so long now, a lot of offices or practices didn't allow for the fact that in the rules, you're supposed to pay that back within 120 days. Well, that actually started August 1st. Well, everybody was saying that, we're still in the pandemic, we're still having problems, we're still having a financial crunch. So I know that a lot of specialty societies went to Medicare and said, can you just waive it? And Medicare said, no, we gave you so much money in HHS funding. We gave you the payroll protection program. We gave you the EIDC. There were so many programs that they put out there. And this was specific to a loan program that allowed you to get advance payments. And many providers, did it. And this was in emergency situations. And remember, this is called the Appropriations Act. And it's something that you have to follow, or I should say Medicare, CMS has to follow what they put into rule that's passed by Congress and passed by the government. So the Continuation Appropriations Act 2021, and it also says Other Extensions Act repayment. This is now how they're going to do it. So they have issued a delay. So if you participated in this program, they said that the delay is going to be 1 year from the issuance of the date that you got your payment. So this was about $106 billion in payments to providers and suppliers as well. So this is a lot of money that was thrown out there. So here's what they said. They're trying to give, providers a lifeline. And they said this was, given to providers so that they didn't have to close their doors, potentially causing a disruption in service for seniors. And now that they are seeing a lot of patients return to hospitals and returning to physician offices, they are mindful of the fact that it isn't 100% back to normal, obviously, because they extended the PHE another 90 days. But here's what they did. They expanded the AAP program to March 28th of 2020 and gave these loans to healthcare providers and suppliers in order to combat the financial burden. So now what they're saying that they're going to do is that providers were required to make payments, as I said, starting August 1st, but with this new action, repayment will be delayed 1 year after you receive the payment. After that first year, Medicare is automatically going to recoup or offset your check 25% of any Medicare payments that you get. So you need to go back and find out when that first payment was received. And that's going to be from that year, you're going to get a 25% offset in your Medicare payments. And then at the end of 11 months after that, recoupment will then increase to 50% for another 6 months. And then it says if the provider or supplier is unable to repay the total amount of the AAP during this time period, so a total of 29 months, CMS will issue letters then requiring repayment of any outstanding balance subject to an interest rate of 4%. That's a lot different because it was at 10.25%. So they have, really given a lot of thought into this and some relief for providers. But I can't say it enough. I didn't recommend that you try to do this, but I know a lot of practices did on top of their PPP loans, on top of their HHS, gifted, funded money. But now basically, and I've said it before, rent is due. They're saying this is not going to be forgiven, and you need to be aware that they are going to, at some point, try to recoup this money. They have to. Otherwise, it's going to bankrupt the Medicare program, regardless of which administration takes over in after November, or I should say in just January. So you have to really be and pay attention to what they're talking about here. This came on a CMS news alert, so you can also find it at cms.gov. I would sign up for these news alerts so that you have them at cms.gov/newsroom. And you can sign up and get these emails just like I do, and they come before anybody else gets them, before they go to social media or anything like that. So it's just helpful that you have that information. So I'm also going to talk to you about 3 different, basically coding and compliance questions that came up that I want to make sure that you're clear on. And one was using the 99211 nurse visit. So I know that a lot of practices are still using this visit for Medicare patients when the provider is not in the office. And that's a problem. I got a question from one of my Washington subscribers that said, Terry, my office manager said we can't report a 99211 when a Medicare patient is seen and the provider's out to lunch. But I don't think that's true. Yes, that's true. If you've taken any of my webinars or my live classes, your manager is correct. So for Medicare claims, the physician must physically be in the office at the time of the service. They don't necessarily have to be right by the nurse or medical assistant side, but they have to be somewhere in the same office building for you to report 99211. And when I say that, it's not, let's say your cardiology, it's not them in a cath lab and your office is attached to it. It means in the clinical space shared by that non-qualified healthcare professional, because remember, this is a nurse visit that you typically use for your medical assistants. So this is not for new patients. It's only for established patients because technically it's performed incident to, meaning the ancillary staff nurse will be using the supervising provider's billing information to get paid for the work. And so to meet those guidelines of incident to, the patient must have a plan of care that's already been created by the supervising provider. And then the nurse or medical assistant would be providing these services as indicated by the plan care. So for example, let's say you had a patient that let's say has blood pressure problems, and the physician treatment plan states that they want the patient to come back in for a blood pressure check because in the last visit they modified their medication because they were having what we call white coat syndrome, meaning that at home it was basically testing as being high. So they wanted to come back in for a blood pressure check with the medical assistant and wanted to assess whether they were having problems with their new medication. So the patient returns to the office, their blood pressure has improved, and obviously it's taken. Their other medications are not bothering them. And the nurse or medical assistant documents that they saw the patient, took their blood pressure, found that the patient is doing, well or fine with their medications. And then they relate this to the provider who's somewhere in the office, and then they can send them on their way, and then there'll be a counter signature as well. That can be billed as an incident to visit underneath the physician. So just make sure you're aware that it's important that you have a reason medically necessary to see the patient and that there is a provider in clinic, or it's not a good idea to bill that. There was another one that came up, and this is kind of coding and kind of compliance. And this is about patients that, or I should say staff members, that are not following or adhering to typical, job description rules. So the question came in, and it said, we recently performed a self-audit and found there are certain issues with our staff members having repeatedly that they don't seem to ever stop making these certain mistakes. For instance, one coder always reports the office place of service, 11, even when encounters take place at the hospital, either out or inpatient. We also have one physician that confuses modifier 24 and 25. Is there a workaround for this? There isn't. But you already really did an important step, and that is that you did a self-audit. And I recommend everybody does that on occasion. Because on a lot of the things that I do, I don't just audit for coding and support of the claim, but I notice that when I'm going through some things, if I'll see, a physician that's constantly using incident to, or a physician that's using time all the time to support their visits, I'll actually start saying, this is triggering me. So can you make sure that that physician is in clinic? Because there's basically too many visits for one person to see all the time. And how are you tracking it? And I find out that incident 2 wasn't followed. Or I'll see a physician that uses time and constantly bills higher level of service. They're in the office for a 4-hour period and they've seen, 25 patients, which again, using time isn't appropriate. So in this scenario, you have to make sure that you distribute throughout your practice what is compliant and don't make it optional. So incorrectly listing a place of service or leaving off a modifier or not linking diagnosis codes with the procedure performed, not only is this going to get you denials, but this is going to be a problem in mistakes. And if you performed, or got asked to do a retrospective audit, meaning, something that's already been billed, you could possibly find yourself having to send refunds and have to self-report. So it's important to always do a health checkup on your practice and make sure that you are being proactive, that things are not being missed. Now, my coding question today is about orthostatic hypertension. So if my cardiologist documented orthostatic hypotension, not hypertension, HYPO, what ICD-10 code should I report for this condition? So you would report I-95.1, orthostatic hypertension. And what this is, just so you know in lay terms, this is what we call postural hypertension. So it relates to a drop in blood pressure when patients go from a sitting to a standing position. And the reading is in comparison to the patient's blood pressure while sitting. So if you've ever seen that and you didn't know what it was, that just can kind of give you a lay person's insight. And you must check the medical record carefully to make sure the cardiologist specifically documented orthostatic hypertension along with the patient's vitals. Otherwise, you could be reporting this incorrectly. So we just want to give you that insight. The Codecast podcast is brought to you today also by Charles Schwab. Be a more informed investor. Follow us for news and insights to help you own your own tomorrow. AboutSchwab.com. So some exciting things coming up. I am going to be hosting a new podcast for a society I belong to called the Nschbc Edge Podcast, which is the National Society of Certified Healthcare Business Consultants that I've been a member of for several years now. And that's going to start on the 10th. We're also going to do it on a Tuesday. So I'm going to have a couple of podcasts that are going to drop on Tuesdays. The Codecast is every Tuesday. And the Edge podcast is going to be the second Tuesday of every month. And that's going to be more business of medicine. This is really coding, billing, reimbursement, and compliance. That's going to have some legal information, some things about, loan repayments, things about compliance, things about HHS. It will have a little bit, maybe some coding in there, but we're really going to focus on more of the high-end business part, of healthcare. So if anybody's interested in that, make sure you check it out in November. The other thing is since we are now 25% into football season, NFL, I've started back with my What the Football WTF podcast for Steel City Underground and for the NFL information. And I have right now through week 4, so check that out at steelcityunderground.com. And you can also see how they're dealing with COVID as well, and also the football follies of the week. They're not dealing with it very well. Some teams are doing what they're supposed to do and some aren't. And actually, it hurt my Steelers because we had to take an early bye or early off week because the Titans didn't follow protocol. And now they're up to, I think, 18 players and personnel with COVID. So definitely interesting when you're not in a bubble. But check that out and hopefully you'll find some things that you like there. So everyone, thank you for spending some time with me. Everyone on this Terry Tuesday, make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.